Hello, I'm Dr. David Johnson, Professor of Medicine, Chief of Gastroenterology at Eastern Virginia Medical School in Norfolk, Virginia. Welcome back to part 2 of ACG Highlights 2023. I want to pick up next with 2 studies as it relates to stool-based testing for colon cancer screening. And the first of which was presented by Dr. David Lieberman from Portland using a multi-targeted stool RNA test called Colosense. This is a new test. They looked at 8,300 participants recruited from 49 states across the United States, so no demographic bias here. And the test was 94% sensitive for detection of colon cancer. Interestingly, 100% sensitive for early stage 1 colon cancers. There were 12 of those. And the sensitivity for detecting advanced adenomas was 45%. And sensitivity for the adenomas that were advanced adenomas that were greater than 2 centimeters was 51%. The specificity overall was 87%. And it's interesting, the maintenance of sensitivity was across all the age groups, and this is likely, they speculate, due to the stool DNA, which is in the current test that is attributable with Cologuard, that is subject to stool methylation. The methylation patterns may change with age, and that may affect then the sensitivity of detection, and that's something that they didn't see in this particular study. Well, turning then to the exact product, the Cologuard, Dr. Tom Imperiali presented the next generation of the multi-target stool DNA as it compared to the non-invasive FIT testing, which is part of the multi-target test anyway. But nonetheless, they were trying to improve specificity. So previous studies, the specificity was 87%. And this particular panel, they had a next-gen panel that combined 3 novel methylated DNA markers with FIT. And they enrolled nearly 26,800 patients. And the specificity actually did increase from the Cologuard previous studies, 87%, to the next-gen Cologuard here of 91%. Specificity for no findings was 90 in the previous Cologuard, and this one was 93. And the sensitivity for cancer detection increased by 2%, 92 to 94%. High-grade dysplasia even better a little bit, from 69% to 75%, and advanced precancer sensitivity from 42 to 43%. So I think this will be a study that will lead to them getting an approval, and they'll likely swap this out for the new panel as this product moves forward. Next to the study from looking at nasal spray for metoclopramide, Dr. Richard McCallum presented this as it relates to comparison with oral use of metoclopramide, recognizing the diabetic gastroparetic population. They have a significant problem as far as incremental costs attributable to relapsing outpatient and inpatient visits, and certainly ER visits. So the idea of the intranasal would be a more predictable delivery and certainly absorption, and that's what they studied. They did a cohort comparison and found that there was a significant reduction as it relates to overall medical costs using this intranasal type of administration. So it's something that I think is on the short term. This was approved in 2020. More and more, I think this is something that we could use. The total healthcare costs were nearly $15,000 cheaper. The drug cost itself was higher, but not significant overall as it relates to between sites. But nonetheless, this is something that I think may be ready for prime time now. Interesting poster as it relates to abdominal paracentesis leaks. And this is a concept that we've all done paracenteses on patients when they have large volume amount of ascites. And the problematic, sometimes these leak, even the best techniques of tunneling in submucosally and then a couple centimeters in and then down, and then attributing to keeping them down on their right side down, potentially decrease the risk from the left abdominal type of approach, potentially using ultrasound as well to maximize. But nonetheless, these were evaluated now with the use of a glue product, cyanoacrylate, which you may be familiar with as it relates to gastric varices and the use in that case. But this is they were randomized to alternating weeks of glue versus no glue, and they followed the leakage effect as it relates to the bandage leakage, and there was a significant reduction during these procedures using the glue. So it's something that I might put on the target for now available. It certainly makes great sense to do this, especially if you have somebody that's had a leak in the past and you may be trying to mitigate that and keep them from the ER coming back. There was about a 5% total documented leak. And again, this is something which may be potentially offset by the cost of whatever the cyanoacrylate, but certainly the incremental costs from ER visits and hospitalization likely offset that. Two others that I wanted to mention quickly. One was the approach to inflammatory bowel patients with vaccination and the new respiratory syncytial virus vaccine. Recognize we do aggressively try and immunize our patients with inflammatory bowel disease. Certainly, these may be elderly or immunocompromised on top of that, but the incremental risk of RSV was studied in patients that were 206,000 with inflammatory bowel disease and over 4 million in non-IBD cohort. And the odds ratios were clearly that the IBD patient had an incremental risk for RSV, about 2.25. So again, the vaccine's out. We should really be applying this to our vaccination strategy in a very aggressive way and an appropriate way as it relates to inflammatory bowel disease patient. The final one, it relates to a concept that we see more and more about microbial involvement in inflammatory bowel disease. This was another poster, but a meta-analysis for fecal intestinal microbial transplant for inflammatory bowel disease, in particular in patients with ulcerative colitis. They evaluated 6 medical databases and came through 10 randomized controlled trials and found that the value of fecal transplant was evident for ulcerative colitis. And certainly this would be something that when you talk to your patients about, recognize it's not approved for use at present, but we're seeing incremental value of this. To that end, the most recent issue of Gut looked at the Rome consensus and derivative of putting emphasis on fecal transplant and inflammatory bowel disease. This is the first consensus conference on fecal transplant and inflammatory bowel disease, and they concluded that it was effective potentially as it relates to inflammatory bowel disease for colitis, but mild evidence on this, and the strong recommendation still remains in the investigation best protocol. But the opposite for Crohn's disease, there was really no evidence of effectiveness. Most of those trials were RCT or non-RCTs. They were pilot studies or anecdotal studies, and there was no evidence for pouchitis. So again, a new guidance on fecal transplant from this presentation, as well as the most recent Rome consensus. So lots of suggestive implications, some of which are ready for prime time, I think, and certainly we'll anxiously await the manuscripts and see these wonderful presentations in full display. I'm Dr. David Johnson. Thanks again for listening.